If you've been watching the news lately, you've probably heard phrases like hospital funding cuts, healthcare budget reductions, Medicare reimbursement changes, rural hospital closures. And maybe your first thought was, okay, but what does that actually mean for me? Because unless you work inside healthcare, those words sound abstract, political, financial, something happening far away in boardrooms and government offices. But here's the truth: hospital funding cuts don't stay in spreadsheets. Eventually, they reach the bedside. They affect wait times, staffing, access to specialists, rural health care, mental health services, emergency departments, and sometimes whether a hospital service exists at all. And today, on Beyond the Stethoscope, we're pulling back the curtain on what hospital funding cuts really mean for patient care. In plain English, welcome to Beyond the Stethoscope. I'm Arne Facklem, nurse practitioner and fellow of hospital medicine with over 30 years in emergency medicine, critical care, transport medicine, and hospital-based care. And this podcast exists for one reason: to explain what's really happening behind the scenes in healthcare in a way that actually makes sense. But before we jump in, a quick pause. If this is the kind of thing you wish someone had explained before you or someone you love ended up in the hospital, then hit the follow button wherever you're listening. And on YouTube, smash the like button and subscribe. It genuinely helps more people find the show. And if you want tools designed to help patients and families better understand the healthcare system, there is the Hospital Survival Toolkit and Medication Guide, and you can find them at ps-health.com. Now let's talk about hospital funding cuts. Because the first thing people need to understand is this: hospitals are not giant piles of money sitting around. Now, yes, some massive academic systems and large corporate healthcare networks make enormous revenues, but many hospitals, especially community hospitals and rural hospitals, operate on surprisingly thin margins, sometimes 1 or 2%. Some actually lose money year after year and survive only because larger systems subsidize them or because states and federal programs help keep essential services alive. And that matters because hospitals are incredibly expensive to run. Think about what exists inside a hospital 24 hours a day: emergency departments, ICUs, respiratory therapy, pharmacy, radiology, laboratories, operating rooms, security, environmental services, house supervisors, specialists on call, all functioning simultaneously around the clock. Healthcare isn't like a restaurant where you can simply close early if business slows down. Hospitals have to be prepared for disaster at all times: a trauma arriving, a stroke, a septic patient, a crashing infant, a multi car accident, a heart attack at 3 a.m. That readiness costs money whether beds are full or empty. Now, here's where things get complicated. A huge percentage of hospital revenue comes from Medicare and Medicaid reimbursements. And many people assume hospitals simply bill whatever they want and get paid. That's not how it works. In reality, insurance companies, Medicare and Medicaid, negotiate or dictate payment rates, and often hospitals receive less than what care actually costs, especially for complex patients, especially in emergency medicine, especially in rural healthcare, especially in patients without insurance. Now, when reimbursement decreases or operating costs rise faster than reimbursement, then hospitals have to make decisions. And those decisions eventually affect care, not because bedside nurses or doctors suddenly stop caring, not because frontline clinicians are lazy, but because systems under pressure start stretching thinner, and patients feel that. Maybe it's longer ER wait times, maybe it's fewer nurses covering more patients, maybe environmental services takes longer to clean rooms, which delays admissions. Maybe physical therapy staffing shrinks. Maybe behavioral health beds disappear. Maybe specialty coverage gets harder to maintain overnight. And one of the biggest things patients notice: the feeling that healthcare workers are rushed, because often they are. And I want to be careful here. This is not about attacking healthcare workers or administrators. Most administrators I've worked with genuinely care deeply about patient care, but they're trying to solve impossible math problems sometimes, such as how do you maintain quality while costs explode? Medication costs rise, staffing costs rise, technology costs rise, supply costs rise, malpractice costs rise. Meanwhile, reimbursement may stay flat or even decline. Something eventually gives. And one of the biggest areas affected is staffing, because staffing is one of the largest hospital expenses. Now, from a patient perspective, staffing shortages can feel subtle at first. Maybe your call light takes longer. Maybe the ER physician seems rushed. Maybe the nurse has 6 patients instead of 4. Maybe the hospitalist only has a few minutes to talk. Maybe discharge planning feels chaotic. But inside healthcare, we can often feel when a hospital is operating under financial stress. People multitask more, support staff gets thinner, clinicians absorb more administrative burden, and burnout increases. Now, let's talk about rural hospitals for a moment, because this is one of the biggest hidden healthcare stories in America. When a rural hospital closes, it's not just an inconvenience. Entire communities lose access to emergency care. Labor and delivery services disappear. Stroke care gets farther away. Trauma care gets farther away. And for some patients, farther away becomes deadly. A heart attack patient who once traveled 12 minutes may now travel 50. A stroke patient loses precious treatment time. A critically ill child may need transfer farther from home. And this is already happening in parts of the country. Now, another thing people don't always realize is this: emergency departments are legally required to evaluate patients, regardless of ability to pay. And ethically, most clinicians strongly believe in that mission. But uncompensated care places enormous financial strain on hospitals already operating on tight margins, especially safety net or critical access hospitals, especially urban trauma centers, especially rural systems. And here's where things become emotionally complicated. Patients are frustrated because bills are enormous. Hospitals are frustrated because reimbursement may still not cover costs. Healthcare workers are frustrated because staffing feels unsafe. Administrators are frustrated because the numbers may genuinely not work. Everyone feels squeezed simultaneously. And unfortunately, patients often experience the downstream effects first. Now, does that mean every bad experience is because of funding cuts? No. Healthcare has always been complex, but financial pressure amplifies existing cracks. And when hospitals start cutting services, patients often don't notice immediately. Until suddenly, there's no overnight MRI anymore. There's no pediatric inpatient unit anymore. There's no psychiatrist available. The ICU is full. The ER boarding situation is worse. The nearest trauma center is farther away. These changes rarely happen overnight. They happen gradually. One staffing decision, one closed unit, one eliminated service line at a time. And eventually communities realize something has changed. Now, I also want patients and families to understand something important. When healthcare workers seem exhausted, it is often because they are trying to maintain safe care inside systems under strain. Most clinicians I know still care deeply, very deeply. They want time to sit longer, explain more, teach more, listen more. But when systems become overloaded, human beings can only stretch so far, and patients feel that emotionally. Now, here's the part where I want to offer something practical, because this episode is not meant to scare you. It's meant to help you understand the environment healthcare is operating in. And understanding the system helps patients navigate it better. A few things patients and families can do: bring updated medication lists, have one family spokesperson when possible, ask questions clearly and calmly, understand delays are often system related, not personal, advocate respectfully but persistently, and when you find healthcare workers who communicate well and care deeply, tell them. Seriously, healthcare workers hear complaints constantly. Kindness and appreciation matter more than people realize, especially right now. Because despite all the financial pressures, most frontline healthcare workers are still showing up every day trying to do the right thing. And that matters a lot. And maybe the biggest takeaway from this episode is this: hospital funding cuts are not just political talking points, they shape the healthcare experience patients eventually receive. Sometimes visibly, sometimes invisibly, but almost always eventually. And the more patients understand what's happening behind the scenes, the better prepared they are to navigate modern healthcare. And that's exactly why Beyond the Stethoscope exists: to pull back the curtain, to explain the system, and to help healthcare make a little more sense. And before we wrap up, if you found this episode helpful, follow the podcast wherever you listen. And on YouTube, like and subscribe so more people can find these conversations. You can also visit ps-health.com for the Hospital Survival Toolkit and Medication Guide, designed to help patients and families better understand the healthcare system in plain English. And until next time, take care of yourselves, take care of each other, and keep looking beyond the stethoscope.